Adjacent segment degeneration versus adjacent segment disease is classified as two different things. And he kept using the words interchangeably, and that's kind of the problem with his argument. Adjacent segment degeneration versus adjacent segment disease, which I'm going to go through with you. Degeneration is actually a classification scheme that's utilized to demonstrate adjacent level breakdown based on radiographs that he was calling disease. Disease is actually symptom development. So if you look at adjacent segment degeneration, there's a classification scheme that's utilized. What you're talking about is newer enlarging osteophytes at the adjacent level, narrowing at the disc space greater than 30% if you have calcification of the ligament, or if you have radioosteophyte formation. That is to be separated from adjacent segment disease, where it's actually symptom development. So you can't use those terms interchangeably, which is what he was doing. So what are the arguments for disc replacement? Pay attention to it. Adjacent segment disease, so symptomatology, so the patient develops symptoms of breakdown, not just evidence of breakdown on films. You maintain motion preservation at the index level, so the level that you actually operate on maintains motion. I'm going to show you data on all of these things here. There's a relatively low success rate of fusion for treatment of multiple segments, especially in terms of patients. We have multiple levels of fusions. The levels of fusions actually go down. And I'm going to talk a little bit about the fusion success rates long term for patients. There's no graft site morbidity. Dr. Tripp does surgery like he does in the 1970s where they take hip grafts. The biggest complaint patients oftentimes have after fusion surgery is actually the hip graft that they take. So they may do well years down the road, but they'll complain about the hip graft site that you took that from. Not only that, but there's actually an infection rate that goes along with making a separate incision to obtain that from a patient. There's no possibility of disease transmission, so you're not taking any type of bone graft from a cadaver or another patient and putting it in the patient because it's all hardware that's manufactured. And the recuperation period, these patients have a rapid discharge. I know he was saying the outpatient surgery for the fusions are quicker, but actually patients get back to their normal daily lives faster with an artificial disc. There's no restrictions for a patient. In fact, the military was using these a lot on their paratroopers for young patients because they can go right back into the field fairly quickly. And then get back to normal activities pretty quickly. And then there's no need for bracing. What are the arguments against the disc fusion? Pseudoarthrosis, so a lack of fusion. So the fusion rates for doing a fusion ACDF are not 100%. There's a real rate of non-union. Adjacent segment degeneration, okay, so breakdown at the next levels, which we'll talk about. Adjacent segment disease, which is the symptom development, and then the reduced range of motion. So again, back to those pictures of the Minecraft guy where you walk around kind of fused. So there's definitely indications to do one versus the other. Not everybody is appropriate for either one of these procedures necessarily. So when we talk about arthroplasty, we talk about single level. They've actually had in the last year or two FDA clearance now for 2-level artificial disc. And in fact, we're behind the European in terms of the trials and stuff. They've been doing single and 2-level arthroplasties for much longer than the US has just because of the FDA. The fusion, yeah, you can use in multi-level disease for sure. Times you use arthroplasties if the patient has an primarily anterior pathology, so you cannot do this if it posterior pathology. You should not be doing an artificial disc in this patient. They can have anterior or posterior disease, you can do an ACDF on that patient. So again, you have to look at the patient's symptomatology presentation to get the appropriate device for them. The important thing that I think a lot of people don't understand is the artificial disc is a motion preservation device. It's not a motion creation device. So if the patient doesn't have motion at the index level, you cannot place an artificial disc within that segment. That's one of the big problems. There's a lot of patients out there that want an artificial disc. They ask for an artificial disc. They do not have motion on their x-rays. They get an artificial disc placed. They have worsening symptoms because now you've created a problem where it probably did not exist. If they do not have motion, that's a good patient for a fusion. Preserve disc height space, so it's really important. Somebody has horrible degenerative disease, again, bone on bone, no disc left. You should not be putting an implant in there that creates space and motion. Collapsed disc space is a better option for that patient with a fusion. Facet arthritis, another thing, again, remember, you consider the cervical space like a triangle. There's an anterior disc space, there's posterior facet joints, there's 2 of those. If the facet joints in the back are hypertrophied and arthritic and they do not move, you do not want to place an artificial disc within that space. Ankylosing, so if the levels are essentially almost fused, you could consider them for a fusion. Sagittal balance is a really critical thing, which again, a lot of people don't understand. When you take a radiograph of the patient in this upright position, and you're looking to see where their head is positioned, whether it's neutral in regards to the shoulders, if the patient has a bent forward position, you cannot place an arthroplasty device into them. They will have a problem because, again, you will create more segmental instability there where they did not have that. So if the patient has a slip in their neck, that would be more appropriate for a fusion. And then, as Dr. Manning was mentioning, patients with severe osteoporosis, significant kyphosis, so forward angulation of the neck, if they have any sort of instability, tumors, or infections, or any type of trauma, those are appropriate fusion patients. So yes, I will concede that there are appropriate patients that are selected for this, and the criteria for an arthroplasty is much smaller if you look at it. There's a lot of arthroplasty devices out there. The arthroplasty has been around for decades. In the US, it's been around since about 2007 was the first time we had FDA clearance here for the first artificial disc. So what are the goal design developments? When they're trying to create an artificial disc, what are you trying to create? Trying to sort of recreate the motion segment. So physiologic kinematics of the space is what you're trying to recreate. It's very hard to do with an artificial device. The human body is very complex from that standpoint. You need something that's very durable, right? So you can't have something put in and then it's going to break down, like Dr. Nanny was saying, over 20, 30 years, and now you have to go back in and replace it. It has to have appropriate fixation. You cannot have these devices spinning out, as you can imagine. It's got to be fixated appropriately. And of course, it's got to be very simple in terms of the surgical technique. Dr. Nanny mentioned that it's much more complex, but these devices have come a long ways from the first generation, 2007. So they're very straightforward to put in. The device is very similar in terms of an approach and procedure compared to fusion. So it's not that much more complex. The difficulty that surgeons, I think, have and patients have is all the criteria in terms of determining who's an appropriate patient to put this into. So let's just talk about spine motion. It's critical to understand this when you're talking about artificial disc versus a fusion. Okay, if you look at the individual levels, C3 through C7, we talk about flexion extension, axial rotation, and lateral bending, right? So it's the entire motion of the neck, which is very complicated. Each level has been studied extensively from an anatomical standpoint in terms of what the degrees are. Usually I'll tell my patients they'll have 5 to 10 degrees of motion per level, okay, on average. These are average numbers that we look at. You can tell that even per level there's a small variation of what the patient can achieve. If you look at flexion extension, it's about 7 to about 10 degrees. Axial rotation is about 5 degrees, much less at the 6-7 level, which is much closer to the cervical thoracic junction. And then lateral bending, about 6 degrees to 9 degrees. So overall, the patient has about 30 degrees of motion. This is excluding the 0-1-2 junction up the head, which provides a lot of axial rotation and flexion extension. So we talked about the nodding and military tuck versus the overall combined motion of the neck. So when we talk about these things, it's important to understand that. AP translation is in yellow there because there's actually some minor translation of the bones at the disc levels. Okay, so there's actually translation, so forward and posterior motion of the levels themselves. So when we talk about that, it's a really important fundamental motion of the cervical spine. So it's not just the rotation, lateral bending, and axial rotation, but the flexion, extension, anterior, posterior translation of the spaces. And it's different at each level, just like we were talking about. So if you see how many millimeters of motion is, usually we'll tell patients that you have, on average, 1 to 2 millimeters of motion, which is within normal physiologic range. Patients that present with greater than that are typically considered to be unstable or have more than normal segmental motion. And you cannot consider the lumbar spine to be the same as the cervical spine because the motion of the joints is, so anatomically they're oriented differently. The cervical spine are much more horizontal. As you get down to the lumbar spine, you're much more anterior posterior. So the cervical spine has significant motion in 3 dimensions. As you get down to the lumbar spine, it's really a flexion extension. So you cannot compare lumbar and cervical spaces the same. Another thing that people don't understand is something called coupling. Coupling is a very important motion that we have in our neck. It's not something we think about. When you have motion in one plane, it couples with another motion in another plane. So when you talk about flexion extension, there is translation of the joints as well. So you flex and you translate, okay? Or if you lateral bend, you will also axially rotate. That's a coupled motion. So motion happens in 2 dimensions typically in the neck, not in 1. So when you're trying to recreate a device, you have to think about these things in terms of recreation. The other thing we talk about is the center of rotation. There's 2 types of centers of rotation. There's the fixed and there's the variable, okay? A fixed center of rotation is something that's defined as rotation of an object around a fixed point. That's the fixed center of rotation. So if you take this, for example, it'd be like a seesaw or a teeter-totter, and you have this, that's a fixed center of rotation. So it's on one point. It does not change. But that is not what we've been talking about this whole time, okay? If you talk about something like flexion extension in the cervical spine, you would say that that's a fixed center of rotation. The radius is the same. That's not what happens, okay? So you think of something, you have to think of coupled motion, which translates into a variable center of rotation, which is what occurs in the cervical spine. So if you take 2 vertebral bodies and you have a motion, You actually translate, like we talked about, when you flex and extend, so you have a variable center of rotation, so things move, okay? And that's very important to understand in terms of trying to recreate neck motions. So it's a variable center of rotation. So this has been described in the cervical spine. And if you look anatomically, if you look at a flexion extension model, the center of rotation is not located within the center of the vertebral body. It's actually located in a separate space. So when you flex and extend, it's actually located on the inferior aspect of the vertebral body. So the bottom 1/3, and actually the posterior 1/3 as well. So you can see in each of those levels here, in the cervical spine, when you're talking about flexion extension, the centers of rotation are actually located not in the center of the vertebral body. So when you have to create a device, you cannot have that center located here. You'll have a problem, okay? So that's how these devices are created. A fixed center of rotation allows rotation but does not allow translation. So that is not normal couple motion. So you try to put that in a patient, they will have increased symptoms. Okay, a simple biomechanical principle. That's a ball and socket, which is what some of the original designs were. We've now gone more to ball and trough and more of a disc type replacement system, which is more like a bag. Okay? So this is a non-physiologic pseudo-translation that occurs. We think about that. But then you have to remember there's facet joints in the back also. Those are used to being slightly translated as well. So remember the tripod, the disc in the front, the two joints in the back all have to be in coupled motion. So this was an analysis of 3 FDA trials that were done. These are IDE cervical arthroplasty trials. So there were 3 artificial discs that were out there that they had done IDE trials. So when they were first coming out for the FDA clearance, they put these trials out. So my mentor and a bunch of these are a lot of surgeons from different areas were part of a lot of these studies. They actually went in there and combined the data to try to see what the overall data was on artificial discs. So they combined the data on these FDA IDE randomized controlled trials. And they got the unpublished data and put it together. So this is not something that's out there published. This is what I got from my mentor. So they looked at the information on what, the Prestige disc, the Bryant disc, and the Pro Disc C. These are just 3 different types of artificial discs that have a lot of data out there, long-term data, 5-10-year data that are out there. They can compare them to single-level ACDFs to see what the data is. So I know Dr. Nanny was showing you a bunch of data. I want you to forget about that. Just blink your minds and pay attention now, okay? So this is the more important part of it. So why do we combine the data? So this actually allows us to have higher statistical power from what he was talking about. So we can do better generalizing to the population, and it gives us better ability to control study variations. So if we look at the data of the arthroplasty patients versus ACDF, the patient selection was actually the same between the two. So there's no major differences between the two. Age, gender, workman's comp, litigation, all these things were the same in all of these patients. There's no demographic difference. If we look at the 2-year follow-up for the patients for arthroplasty versus ACDF, the overall follow-up data was about 94% in the arthroplasty and about 87% in the fusion. So pretty good overall follow-up for 2 years on these patients, okay? If you look now at segmental motion between the two, it was maintained for the arthroplasty data. So I know he mentioned to you that patients do not maintain their motion. So arthroplasty motion was maintained in these patients. So if you look at the preoperative and then the 2-year follow-up motion, 7.26 preoperatively, finish up with 8.14. So they continue to have motion maintained at those levels in 2 years. If you look at the fusion rates at 24 months, so 2-year follow-up fusion rates for the ACDF patients in general, if you look at those patients overall, for the patients, ACDF rates were 97%, 94%, 90%, and overall 95%. So 95% success rate, not 100 in terms of fusions. And we know that this is a very often quoted number for fusions. Some patients will not fuse. If you look at the NDI, so Neck Disability Index, he was talking about that. This is one of the measures that we use to look at patients and their pain. If you look at these between the ACDF and arthroplasty, if you look at all the data, there's no statistical difference, which is what he was talking about. So overall, there's no favor of one versus the other. I do not dispute that. If you look at the SF-36, which is one of the pain scales, no significant statistical difference between the 2 artificial disc versus the fusion rates. If you look at the neck pain scores, they were also not, in terms of the VAS scores, they were not significantly different between the artificial disc and the fusion rates. So again, I'm not disputing the 3 comments that he made. Arm pain scores, not statistically different. So all the same outcomes between the 2. So we haven't proved that the artificial disc is a better device than the fusion. Neurological success, however, does favor arthroplasty. So poor Dr. V over here, actually you wouldn't have been qualified because he said you have to be young for surgery. He kind of threw you out on that one. So neurological success favors your arthroplasty. Okay, so if you have somebody with neurological deficits, long-term arthroplasty is favorable of the two. Fewer secondary surgeries in terms of arthroplasty versus fusion. I know he told you the opposite of that. He talked about heterotopic ossification. I don't know where he pulled this literature out of. I think it was 2002. But absence or presence of bridging bone, if you look at the overall numbers, Prestige only had 1, the Bryant disc had 0, and the Pro disc had 3. It's extremely low rates. In fact, what we do, if you treat these patients with artificial discs, we have a protocol, you put them on NSAIDs, so anti-inflammatories like Advil. For 2 weeks after surgery, they found that reduces the amount of heterotopic ossification after surgery. Adverse events, return to work, and overall success, there was a significant difference in the data collection, so we couldn't look at those things in terms of the IDE trials and say what was the outcomes for these. So they couldn't do anything with their combined analysis, so we couldn't say that there was any sort of better or worse outcome with an artificial disc versus infusion. So just in summary, in case any of you forgot, the NDI, SF36, the mental component score, the SF36 pain scores, neck pain, arm pain scores, not statistically different. So we'd say, fine, pick your portion, whichever one you want. The arthroplasty does demonstrate superior results in terms of neurological outcomes and neurological success. At 2 years, it has significantly lower rate of secondary surgeries, despite what he claims. And the reoperation rate for adjacent level disease was significant with fixed effects model only, and I didn't really talk about that. In conclusion, ACDF arthroplasty demonstrates excellent 2-year surgical results. It's associated with a lower rate of secondary surgeries and a higher rate of neurological success at 2 years. And it may be associated with a lower rate of adjacent level disease at 2 years. Okay? There's a ton of studies that have come out in terms of arthroplasty versus fusion. We're not going to go through all these because it's getting late, and I know you guys are all falling asleep and you already know who won. So literature summary for you. If you look at the multiple meta-analyses and longer sort of long-term studies that have been out there now, there's no superiority of an ACDF. Nobody's going to say, oh, an ACDF is way better. Most, if not all, report superiority of an arthroplasty. Okay? And 2-level studies are starting to come out now, and I don't want to talk about those because those results are not as much as we have for single levels. But then people argue, well, don't we manufacture the data? You know, are the PIs, the guys that put these in, are they biased in terms of their outcomes? You know, is there a financial incentive for us putting these in? And do patients with an ACDF expect to do worse, right? So if somebody goes into a study, the problem is they have a lot of crossover. If you look at the study data, when a patient goes in for a study, this is what they found with the original studies. When a patient is told you can be in a study and have an artificial disc versus the fusion, and then they get the random drawing that day and they find out that they're going to get the fusion and not the arthroplasty, they pull out of the study. Okay, because they wanted the arthroplasty. So there's a lot of patients that do not participate. That's where they had some difficulty with enrolling patients. So let's just do a couple things that he talked about. Cost-effective analysis, he brought this up, and comparing a single-level cervical disc replacement to a single-level ACDF itself. So when we talk about costs, you talk about the cost of the implant. But for patients and everybody, it's not just the cost of the implant, it's the quality of life that's achieved after that, right, in general. So if we look at a 20-year outcome of an arthroplasty or artificial disc itself, the cost estimate ratio of sort of the cost of the device and the quality of the patient is $3,000 for the disc replacement, and it's 2 to 3 times that for the artificial disc. Okay, so the quality of life outcome to cost. It's not just the direct cost that he was trying to cheat you with. Okay, if the patient survived 20 years. In fact, if you looked at the sensitivity analysis of the disc replacement itself, the patient would only need to survive for 10 years for that to actually be a more cost-effective device. So 10 years. If you look at the cost-effective ratio for both disc replacement and artificial disc versus fusion compared to other medical and surgical interventions, and this is an interesting slide because if you look at a total hip replacement, it's $4,000, $600. Treatment of medical hypertension, so medications and all these are $24,000. And for a lumbar disc, that means $29,000. So if you look at the overall cost, we may see the device is costly itself, but the quality of life measure is actually very low. Okay, so it's a very good device to put into patients. Here's a paper published in 2014, which is a 7-year follow-up. This is a Prestige, so just one of the artificial discs that's out there. Again, there's a ton of slides I'm not going to bore you with. If you look at the neck disability index score, you can see initially, so the Prestige artificial disc is down below, and this is the fusion rates here. So over time, you see that the significance of the NDI after 1 to 2 years starts to take effect. Okay, so patients don't notice significant difference in the beginning, but they start to notice it long term. If you look at secondary surgery at the treated level, so artificial disc is on the left versus the fusion rates here. I'm not sure what data he was quoting. The number of fusion patients, 30 versus 11, so significant difference between the number of surgeries that had to occur in the fusion versus the artificial disc. These are revision surgeries, implant removals, and removal of the device electively. Talk about supplemental fixation, reoperations. There is similar reoperation rates down here. And supplemental fixation where patients had to get a bone growth stimulator because they did not fuse were 7. So patients actually had to have supplemental fixation with another, probably more costly device. Adjacent level surgery, you had mentioned this as well. They followed these patients for 7 years. There are 11 patients in the investigational and 24 control patients. So the rate of adjacent level was 5.4% in the artificial disc and 11% in the fusion level. So you can see for yourself which one was higher. So I can show you more literature, but repetition, unfortunately, is redundant. I don't want to bore you. Too much repetition is boring, and you can trust me.